Good morning and good evening. My name is Saraswati Vedam, and I'm coming to you today from the traditional and unceded territories of the Coast Salish nations, the Musqueam, Tsleil-Waututh, and Squamish peoples of Western Canada. I'm grateful to be doing my research and serving families here in this beautiful land. And I'm also grateful to my own ancestors in Chennai and Bengaluru in South India. Thank you, Dr. Aparajita, for starting the conversation about respectful maternity care. And I'm here to speak to you today about equity in maternity care and how participatory research that centers the most marginalized can transform how we understand what quality care is. My lab engages in a number of participatory research projects, and I'm going to talk to you a little bit about the research, the methods that we use, tell you some of the results, and then tell you a little bit about what we're doing to respond to those results. We'll focus our discussion today on two studies from Canada and the US, which comprise over 6,000 people, and touch a little bit on our current work here as well. We have a number of funders. I'm grateful to them, and I have no conflicts to declare. And I want to start the conversation by reminding us that when we try to enhance quality in research, particularly health services research, it's really important to ask the right questions in the right way, ask the right people, and ask enough people. Otherwise, you don't get the information that's credible. So in our studies, we include women from different cultural and socioeconomic backgrounds, as well as different identities. They include immigrant refugee women, people who have experienced homelessness, poverty, or other social risks in North America, as well as people who live with disabilities, who live on the street, people who have identities that put them at risk. Our process is to start by creating a team, including a steering council of service users. Those service users help us identify what we should study. They help us seek the funding. They help us create the study tools, decide how to recruit the participants, how to explore and understand the findings that we get, and then to identify those key messages, who to tell the story, how to tell the story, and where to tell the story. We always have a multidisciplinary team, including clinicians, doctors, midwives, researchers from many different disciplines, as well as the NGOs that serve those populations. We find when we all work together, we actually can design study tools and engage people and build trust across. Because there's, of course, particularly for disenfranchised communities, there's a history of being overstudied or understudied or being studied without transparency, without ethical procedures. And so that trust building has to start from the start, and everybody needs to be at the table from the start. In the studies that I'm going to talk to you about, the community members chose the topics. They said they wanted to talk about their access to models of birth care, and particularly about their experiences with decision-making, respect, autonomy. And in the US, it was quite important for them to see someone measure the impacts of racism, mistreatment, consent, when they declined care, what happened, and also what they felt built health and well-being. We, of course, translated it, and currently our studies are translated into 8 different languages. By using those methods and engaging the service users right from the start, as well as the NGOs that serve them, we will be able to get participation in our US study from all 50 states. In Canada, in BC, we also got a representative sample just through their social media networking, because there was so much engagement and trust in the study tool itself. We were able to oversample, as was our intention, for communities of color. We were focusing on communities of color and those people who planned community births, because neither of those communities had been able to share their own experiences and their perspectives in previous health services research. So here's a taste of the types of questions that we ask and the results we got. So when people reported on their decision making, over 90% of people in both US and 95% in Canada, 91% in the US said it was very important that they lead the decisions. Only about a third of them wanted their provider's input, and only 26 women among 2,700 respondents said that it was not important for them to lead the decisions. Yet when we asked them who was actually making those decisions, we found that for operative deliveries, particularly cesareans and forceps, and for inductions, it was the provider who was making those decisions. You can see that's all the green and blue portions of the data. When we explored a little more deeply about what that looked like, what was the process of decision-making, we used a validated scale called the Mother's Autonomy and Decision-Making Scale, which it would allow them to rate whether or not they understood the different options, whether they had enough time to consider their options, whether they could choose their options, and what those conversations went like. When they received an autonomy score, we used those autonomy scores as outcome measures, and we were able to demonstrate very significant differences by place of birth. So when they were in the community, in their own home, or in a birth center outside a facility, they experienced greater autonomy. But once they were in a facility, the differences in loss of autonomy were significant. We also found that type of provider mattered, that in our sample, we had about half of people who were cared for by physicians and half by midwives. And we found that there were large differences between the amount of autonomy they had. And that could have been the model of care, could have been the amount of time that the health system allowed that type of provider. It could have been the way they were socialized and whether or not engaging in those conversations was part of their routine practice. That those findings persisted when we used the Mothers on Respect Index, which talked about how comfortable people felt asking questions, whether or not they held back their questions because they felt that their provider was rushed, or if they had a difference of opinion, and whether or not they felt like their identity interacted with how well or poorly they were treated. That also resulted in a range of scores. And when we looked at the lowest 10th percentile, the poorest scores of respect, we found that, in fact, communities of color had reported the lowest respect. When we looked a little further, what we would consider actually in any system, human rights violations, being shouted at, being scolded, having treatment withheld, being forced to accept treatment, being ignored, where providers refused to help them or failed to respond in a timely manner or threatened them. We heard that the most common threat that was used to coerce them into compliance was they were threatened that if they didn't comply, they or their baby would have a poor outcome. And this was for all kinds of things, for declining antibiotics, talking about position for birth, whether or not they accepted recommendations for episiotomy or cesarean. In fact, we found that 1 in 6 women in our full sample experienced one or more types of mistreatment. And when we disaggregated it by race, we found that it was double. 2 in 6 people, a third of the sample, and this is the same as what Megan Boren and colleagues have discovered in low and middle income countries, in 4 countries in Africa. This was exactly the same rate. It is global. Those who are most marginalized experience the worst outcomes and the worst treatment. We again, place of birth matters. Facility birth is most associated with mistreatment. Type of provider matters. Again, differences between physicians and midwives and what the models of care represent. Whether or not decision-making, enlisting, kindness, compassion, respect are core to the way those interactions happen. And we found that, in fact, other types of social determinants of health, which we know also put people at risk for disparities in outcomes that are physical, that is having low socioeconomic status, having a pregnancy risk, having some sort of social risk like homelessness or substance use. We know that those disenfranchise them both with their maternal and fetal physical and medical outcomes. And now we know that, in fact, they are also more at risk for mistreatment. When we asked people about what happened when they declined care, we found that if they had a difference of opinion with their provider, 79% of those people were mistreated. Women of color were 2 times more likely to have the procedure performed against their will. And sometimes providers kept asking them until they agreed or asked someone else to convince them. The rate of mistreatment by type of birth was also significantly different. Instrumental birth, when they had an unplanned C-section, they're already scared, frightened, confused, having an outcome or a procedure that they had not chosen, that seemed to also increase everybody's anxiety level and poor behavior. So how do race and other factors intersect? In the US and Canada, Black and Indigenous people experience the highest rates of maternal and newborn mortality. That's often blamed on the person's circumstances, poverty, education, or pre-existing health status. But let's look at the effects of discrimination by identity in relation to those factors. We find that when people have additional socio-demographic challenges, whether or not it's their first pregnancy, they're young, they have low socioeconomic status, they have other types of complications, social risks, they are more at risk for mistreatment. Why does it matter? We know that mistreatment is connected to mortality. You heard Dr. Arpavita talk about it. We know that from California, from Europe, from many countries around the world, that when healthcare providers and health service users are not in good relationship, there are delayed responses to clinical warning signs. In fact, it leads to death, both for mothers and for babies. And it's even more exacerbated during the current climate of COVID response. And yet when you ask communities themselves, they say they don't rely on us. They've learned not to rely on the providers, and because they are not getting the help that they're seeking. They, in fact, are just relying on themselves, on their family and their friends. When we ask about whether or not they needed certain safe house from abuse, counseling, nutrition, help to quit smoking, or housing subsidies, we find that the amount of help they got, that's the red bars, absolutely absent for some of those factors. And the unmet need is 2 to 3 times worse for Black and Indigenous communities in Canada and the US. So how do we tell these stories? How can we center the lived experience and change our public understanding and provider understanding and policymakers' understanding of why it matters? We've had meetings with service users, and they're talking about social media, campaigns, I Decide, My Body, My Birth. They're asking and requesting that celebrities and spokespersons and media elevate their concerns. They want training for leaders, they want public information campaigns on human rights, and they want increased access to the providers and models of care that reduce mistreatment. We have created a play where we've dramatized some of the actual words, completely the words of the users and we've used that play to be a springboard into town halls and discussions about how and where to take this information. In fact, they've asked for health professional educational courses. So we created a course called Dialogue and Shared Decisions to teach healthcare providers involved with maternity units to focus on the service user in the decision-making process. We have to see ourselves, I think, now as allies. We have to make sure that human rights and childbirth becomes a standard of care, and seek funding that will support and incentivize this re-education, our accountability and transparency. We need trauma-informed care, implicit bias, and anti-racism training. We need the basic education about what autonomy, respect, kindness, and compassion look like. And we need tracking tools. We have created one tool to track and account for human rights violations, where people can report on the types of violations they see and what it looks like, and achieve some accountability. We've also gathered a number of guidance around human rights and gender-sensitive care during COVID and beyond, and we've mounted it on a hub that is can be widely accessible, and where people from a variety of stakeholder perspectives can go in and find evidence-based guidance at their fingertips. And I'd like to acknowledge the communities that have helped me bring this work forward. And if you'd like to learn more, you can visit our lab. We have a website with a number of lots of information about our projects.